Hey everyone, this is Mrs. Lewis, and today I'm going to talk about dialysis. This is threats to elimination, and we are going to get started. I did not include your objectives, but your objectives can be found in your module, and I would highly suggest to make sure that you review your objectives, because usually when we're making a PowerPoint or we're making our notes, then we look at the objectives in your module. So definitely go there, look at those. And again, this is docery, so you will have to write some stuff down or take notes. Is highly recommended. So I'm going to get started. What is dialysis exactly? It's just movement of fluid or molecules across a semi-permeable membrane. And this is just basically what it is. And it goes from one compartment to another. And usually it's used to correct fluid and electrolyte imbalances, and to remove waste products, including water. So remember, the kidneys are not working properly, so they can't remove the waste, they can't remove as much water, and this process helps with both. And sometimes it is used for treatment of drug overdoses, but a majority of the time it is used when someone is in end-stage renal disease and their body is building up uremia and having some symptoms. Their GFR is low, and they are not, or sometimes they produce some urine, sometimes none at all. So these are some of the manifestations, and we are going to go more into that. But let's talk a little bit more about this uremia. So dialysis begins when the patient's uremia can no longer be adequately managed. So we talked about the buildup of that waste, and the paresthesias, the uremic frost on the skin. So that uremia is just it's poison, and if they can give the medications, we give the phosphate binders, we give the the calcium acetate and different things to combat some of this. But over time, and as the glomerulus doesn't function as well, then it can no longer be adequately managed, and they have to go on dialysis. So end-stage disease is treated with dialysis because usually lack of donated organs, patients sometimes physically or mentally unsuitable for a transplant. Some people do not want a transplant, so why they decide, and then some people decide they don't want to go on dialysis. We've taken care of them at clinical. Some patients that they're 75 years old and their kidneys have failed, and they decide I just want palliative care. I don't really or I want hospice. I don't really want anything. I just want to die with dignity and in peace and comfort. So that is an option too, if someone decides that they do not want, because it's not a cure, it's really just a palliative type care that prolongs life a little bit longer, especially if they're not a candidate for transplant. And then some people do, they go on dialysis while they're waiting for a transplant. So let's talk a little bit about osmosis and diffusion, because that is the process that occurs. And diffusion is basically movement of solutes, right? It's the solutes from a greater concentration to a lesser concentration. And that occurs during dialysis as the substances of low molecular weight pass from the diacylate into the patient's blood. And the purity of the water and everything that they use, they call them a bath, that is monitored and controlled. Usually in your clinics there's one person, well, several people, but one person that's over all that. They're over each person's prescribed diacylate. So it's monitored and tightly controlled. And then osmosis, which is just movement of fluid from an area of lesser concentration of solutes to an area of greater concentration. So that is your osmosis. So your osmosis is often, the water movement of lesser to concentration to the area of greater. Now, glucose is added to diacylate, especially in peritoneal. A lot of your peritoneal diacylate is full of glucose, so it creates an osmotic gradient across the membrane, pulling that excess fluid from the blood. And glucose can be in your hemodialysate bath as well. So let's just talk about a few general principles of dialysis. It occurs using ultrafiltration, which is water and fluid removal by creating a pressure differential between blood and diacylate solution. So you get this pressure differential and between the blood and the diacylate. Hemodialysis is an artificial membrane. The dialyzer is used, and I do have a picture of that on another slide. And then peritoneal, the peritoneal membrane is used as a semi-permeable membrane for osmosis and ultrafiltration. This is a Tinkoff catheter, which is the catheter that you will see with peritoneal. So they put a catheter, and all your peritoneal patients will have a catheter coming out of their abdomen. It'll be just a tube, and then for dialysis, they hook up the diacylate solution. It goes into the abdomen, and then it sits there. Ultrafiltration occurs, and it goes out the drain bag. So that is peritoneal in a nutshell. You have your solutions, and I put they could be 1.5 to 2.5, 4.25% glucose solutions, depending on the person's weight and all, and their need, what works for them. And they're usually 1 to 2 liter bags, so they're big bags, and the composition's similar to plasma. Usually the bags are warm to body temperature. So you don't have all this cold liquid in the abdomen. That's your Tinkoff catheter. It's inserted via surgery, and there's usually a Dacron cuff, which, if you remember from studying about central lines, the Dacron cuff kind of helps hold it in place, and it decreases infection risk as well. Usually there's a antimicrobial inserted into that Dacron cuff. 12% of patients on dialysis have increased risk of infection, an increased risk of peritonitis. Often with peritonitis, they'll see pain, fever, cloudy drainage. Now, they can have a little bit of pain as the diacylate fills up their abdomen. Just think about all that fluid in your abdomen. I mean, it's going to be a little tight, a little painful. So there is a little pain just in general with all that pressure in your abdomen. But if all of a sudden there's pain, different pain, pain does usually accompany infection at times. So there would probably be a difference. It wouldn't just feel like pressure pain. Fever, cloudy drainage is another sign of infection. So all of those things go with your peritoneal dialysis. Now, as far as using that Tinkoff catheter, usually there's a 7 to 14 day window after surgery, And then 2 to 4 weeks after surgery or implantation, and the site's clean, they can, and free of redness, they can use. But once healed, they can shower, they can pat it dry. Some wear dressing over it, some don't. But they can't just sit in a body of water, but showers are okay. So with peritoneal, there are 3 phases: inflow, dwell, and drain. Inflow is infused through the catheter around 10 minutes, and once it infuses, it's clamped off. They can have pain, like I said, so you may have to go a little slower with the infusion if it's painful. Then there's a dwell time. That's how long it stays in the stomach. It can be 20 minutes or it can be 8 hours. There's different ways that this can be done. It just depends on the method. We'll talk a little bit about that. And then the drain lasts 15 to 35 minutes. Make sure there's no kinks in the line. You can facilitate drainage with massage. Sometimes they need to change positions. So that's the drain phase, when it's draining out. You have different types of systems. The APD is your automated, that delivers while sleeping. Usually, sometimes during the day, there can be a need to have an exchange. They call the changing out of the solutions an exchange. So sometimes during the day, they need an exchange. CAPD is continuous. That's ambulatory. Those are manual exchanges. They can be up to 4 times a day, usually like 7, 12, 5, 10 p.m. So those are throughout the day. So they're basically walking around doing dialysis, doing peritoneal dialysis, and as it's draining, and it's draining down. With peritoneal, usually you have some glucose monitoring because, again, the dialysate is full of glucose. And with peritoneal fluid and water is unrestricted, which is very much a benefit, because in the other forms of dialysis, in hemo, there's more restriction. Protein, you can have more protein, a little more protein than you can with the other dialysis. Sodium, a lot of these are still individualized. Potassium's usually not restricted, and that's a good thing with peritoneal. So potassium is restricted in hemo. And then phosphorus is individualized as well. Most of the time they still will be on the phosphate binders, but it's more individualized as well. So let's talk about some pros and cons. Your pros are definitely a short training program. There's a lot of independence. People can travel. There's fewer dietary restrictions, as I just discussed. Greater mobility. They can move around and do things. A lot of people enjoy peritoneal over hemo. Some cons is the infections, peritonitis. So you have to use meticulous aseptic technique and be trainable to do peritoneal dialysis. It depends on the support system, or the patient, the client, and how trainable can they learn this. That's a big thing with peritoneal, because you don't want them to be coming in with frequent infections if they don't understand. Some problems too are hernias, because you think all this fluid in your stomach. Lower back problems, atelectasis, pneumonia, because think about all this fluid in your stomach. They're not getting the deep breaths. Their lungs are not able to expand as much, because they're being, all that fluid's pushing up on their diaphragm, and it displaces it. So that's some problems that they can have. So you might see even some pneumonia, or frequent pneumonia, bronchitis type things with your peritoneal dialysis patients. Protein loss. So with peritoneal, they can lose up to 10 to 20 grams a day, hence the reason they can have a little bit more protein on peritoneal versus hemodialysis. All right, let's talk about hemodialysis. With hemo, you've got 2 needles, as you can see here. I like this picture just because it's a little more visual for me. I'm a visual person, and this picture shows that with hemo, you've got the 2 needles. This is your hemodialysis patient that is going to your clinics. There are other ways to do hemodialysis. We will talk about those, but this is the way that if you're a chronic patient, you're going to the clinic, you're getting hemo, you're going to have 2 needles in your arm while you are being dialyzed. And they are big needles as well. But usually the graft is the graft is big and it needs the bigger needles. So the needles, the blood goes from, as you can see, the arterial side of the graft, and it goes into the dialyzer, and then it goes to the pump. So there's a machine, and in that machine, we often will give them their epoetin or Epigen. We'll give that IV. But remember, Epigen can also be given sub-Q. And often there's a heparin as well, because again, you got to keep it heparinized so that it's not clotting up in the tubes and in the machine. So all of that will be there. They'll be on a heparin drip as well. It's very diluted heparin, but they are definitely on heparin during this process. And then the dialyzer, that's a picture of a dialyzer. Again, those are also per patient which type of dialyzer. It's prescribed as well. It's a long plastic tube with fibers that are semi-permeable membranes. This is where your ultrafiltration occurs. Remember, we talked about that. With hemo, the gradient's created by increasing pressure in the blood compartment. You get this positive pressure, and then the decreasing pressure in the diastolate compartment, which is your liquid. So you get the negative pressure because of the liquid, and then all that waste and the extracellular fluid moves into the diastolate because of the pressure gradient, and then the excess fluid is removed by that pressure differential between the blood and the diastolate solution. So that is kind of how it works there. As far as vascular access sites, so I've got 2 here, and this bottom one is your graft. It's a synthetic material. It's called AVG graft, or arterial venous graft, and it's synthetic usually. As you see, the white can be bovine, or it can just be a plastic. So those are surgically implanted, or it's a surgical procedure where they anastomose the artery, usually brachial, and a vein, usually antecubital, so that they can get this arterial venous pull that they need. And then remember, the blood goes back into the venous side, and they pull from the arterial side. And these often can be risk for thrombosis and infection, because again, it's this bovine or Teflon material that is not your own, so they are a higher risk for thrombosis. One good thing about it, though, is it can be used quicker than the other one. So the other one up here at the top is your AV fistula, arterial venous fistula. It has the best patency and the least complications. Although a con on that one is that it does take longer for you to be able to use it, because the blood has to become kind of arterialized, and as it has to develop and become arterialized. And like I said, it does take around 6 weeks to months for this to occur, as this becomes, the vein becomes arterialized. It just, it's essential to provide rapid blood flow needed for hemodialysis. And with this one, like I said 6 weeks to 3 months. It could be even longer, just depending on how well this occurs and how fast this occurs. But the vein artery anastomose, and the vein becomes arterialized. Steele syndrome could happen with either one of these, and it is just too much arterial blood is being shunted. So what you would see is probably like a pallor. The hand might be pale. You might have a lack of pulse or a faint pulse. So any of those things could be a complication, and it could be an emergency. They may have to take them back to surgery. I have seen the hand still have a pulse but be somewhat cooler and have some pallor, and the doctor is fine with it. But basically the pain is because pain, you have less blood flow, you're going to have a little pain, and that's just some arterial blood is being shunted or stolen from that extremity. So that can happen. Aneurysms can develop, and they can, this is a problem, but aneurysms can develop because you're as it becomes bigger with the AV access, arterial venous access, an aneurysm can occur. So that's another problem that can occur with your access devices. Now, with your access devices, feel the thrill, hear a bruit, right? Feel the thrill, hear a bruit, no blood pressures, no venous punctures in that arm. So these are your patients that'll have a sign over the door or a bracelet on, an armband on that says no blood pressures, no venipunctures in that arm. And most patients will know. They'll be like, no, don't mess with that arm. That's my lifeline. That's my lifeline. So, all right, so here's some temporary catheters. They can be used a little bit longer term. Some of the cuffed long-term ones can, but usually they're used for temporary, for waiting for the graft or the fistula, or waiting for that fistula to arterialize and develop, or something happened, their graft clotted off, and they still need their dialysis, so they need a vascular access device, which is a central line. And often you will know that they will tell you, or sometimes their dialysis catheter will be wrapped in gauze, letting you know you're not supposed to be using it. So if you get one of those, sometimes you have to get a special order to use the little pigtail that's on it. You can use it, but usually you have to get a special order. So just be aware of that as well. Let's just talk about procedure for dialysis. So pre-procedure, patient comes into the clinic and they're gonna weigh them, right? Well, first, before anything, while you're getting ready for the patient, you're priming all those lines, getting everything ready. The tech does it, the RN does it. You're priming those lines with normal saline. Then they come into the clinic. They're all wanting to be first, so they're probably lined up. And the patient weighs in. We assess the kilograms and the fluid to remove. And that's something that the RN does, because that's assessment. Your techs often will weigh them, but we do have to decide on how much fluid to remove, and usually there's a protocol there. And then they weigh in, weigh out, so they'll weigh out when they leave to see how much, and all this is documented. And the difference determines the ultrafiltration, how much you're going to take off, and that kind of thing. We often assess temperature, vital signs, condition. They're getting frequent vital signs. They're usually hooked up to a machine. The condition of the site. All of this has to be documented. Like I said, frequent monitoring. You have to be alert because, heparin's infusing. Sometimes too much fluid's pulled off and they can bottom out their blood pressure. So there's different things that can happen. But we're doing vital signs frequently. And we're sometimes only only give fluid if they have a blood pressure that bottoms out. There's a formula we use. Some places call it a hot shot, which is just like a sodium infusion, but it's more concentrated. It's not a big, huge bag of fluid, because you don't want to give them a bunch of fluid that you're trying to take off. So there are some things you can do if their blood pressure drops out, lay them back, different things like that. But the goal is for them to not happen. And you only want to give the fluid at the end, because that's just rinsing the blood back in. And or if the blood pressure drops, you still give a little, but you give minimal. And like I said, usually you give something else with that. That's a good to know. That's not a need to know. But a need to know would be you just don't, you don't load them up with a big, huge bunch of boluses of normal saline either. And then all the blood's flushed back into the patient. Of course, they still lose some blood, hence the reason they're anemic and the fact that their kidneys are not producing or helping with the erythropoietin. So needles are removed. There's firm pressure applied. And remember, it's arterialized, so you're going to hold it for 3 to 5 minutes. Usually the patient will hold it. They know they do this every week. And then you're monitoring them for hypotension. That can be a complication. When I say complication, that can happen. They can have that disequilibrium syndrome, different things like that. But it's kind of expected for them to be a little hypotensive because you just removed a bunch of fluid from them. And if it's too low, we won't let them drive. We'll make them wait a little bit. Usually, they usually start feeling better. We don't want anybody really to drive after dialysis, but some people do. And, it's chronic. It's a chronic environment, so you get to know the ones that do, and you have to hold them back and not let them drive if their blood pressure's too low or if they're feeling dizzy. So a lot of that has to be documented as well. All right, so post-effectiveness. It's an alternative transplant. It can ease many of the symptoms. It can prevent certain complications as far as renal failure. But the individual adaptation varies. Most feel positive because it makes them feel better. All that fluid and waste building up makes them feel horrible, and the dialysis helps them to feel better. But some cons or complications, you get the hypotension. And they can have muscle cramps during the procedure as well. Loss of blood again because some of it stays in the dialyzer, some of it stays in the line, so they do have a little bit of loss of blood, which contributes to their anemia. And then there's hepatitis risk. We've gotten a lot better with that. Used to that was a bigger prevalence of hepatitis, but a lot of the chemicals we use do get rid of the hepatitis. And then just increased risk of infections as well is another complication of dialysis. And then you've got your CRRT, which is continuous renal replacement, which is like dialysis, but it is a more physiologic way. So it's slower, it's over 24 hours, and it's a little bit more like the kidneys because it's a slow process, and it's for those people that are in ICU, usually that are hemodynamically unstable. So someone that's septic shock, or someone that is, they're not able to handle those huge fluid shifts, okay? They can't tolerate it. And that is all I have. And if you have any questions, please find me, look me up. Find me and Mary Lewis and ask me anything. And I hope that you have a good rest of the day.